With more than half of Americans reporting that they consume alcohol, drinking is a big part of American culture. Happy hours dominate corporate get-togethers, and sporting events rake in millions of dollars from beer sales. Even light drinkers may still enjoy a glass of wine with dinner. But with such popularity comes a greater risk for misuse. The 2024 National Survey on Drug Use and Health reports that nearly 28 million people ages 12 and older had alcohol use disorder in the past year. That's 1 in every 10 people. And yet, barely any of them receive treatment despite the fact that there are multiple FDA-approved medications to reduce alcohol intake.
So one of them kind of stops the breakdown of one of those byproducts that makes you feel ill when you drink alcohol. So that byproduct accumulates and then you drink and you feel bad, right? Other ones act in the brain, really more on the reward system, trying to reduce the effects of alcohol.
That's Alex DeFelice-Antonio, an appetitive neuroscientist and associate professor at the Fralin Biomedical Research Institute at Virginia Tech University. It's estimated that only 2% of people with alcohol use disorder use these medications. Experts say that part of the problem is stigma, while the other factor is simply a lack of knowledge about these options. However, a potential new treatment could change all of this. GLP-1 receptor agonists like Ozempic have never been more popular with people across the board, from celebrities to your next-door neighbor. And though these products are known for their weight loss effects, DeFelice-Antonio says researchers have noticed a side effect of these medications that could make it a new option for alcohol addiction.
Preclinical literature, the rodent literature, has actually been around for a long time. So people were examining Exendin-4, which is similar to exenatide, one of the very early GLP-1 medications, and giving that to rodents and noticing that they were drinking less.
And unlike the current medications used to reduce alcohol intake that only act on one system, GLP-1s are showing early signs of working both in the brain and other parts of the body.
We know that, or at least in our study, we're observing some of these peripheral effects. We have evidence from other RCTs that there might be central effects in the brain. And so it's possible, we don't have enough data to conclude this, but if the GLP-1 drugs are kind of able to engage both the periphery and the central mechanisms, that might be an effective way to reduce drinking.
Again, this is early research, so there's still more studies that need to be done. In fact, DeFelice-Antonio says there's still some debate within the neuroscience field about how much a GLP-1 drug can get into the brain.
They definitely have effects in the brain. Some of their effects of nausea are in the area postrema. There's other effects of for this kind of feeling of fullness, also in the brainstem. But there's a little more argument as to how these drugs are having their central effects. We know that there are GLP-1 receptors expressed throughout the brain, but how much of the drug is really getting into the brain is something that there's kind of less really good evidence on.
However, she says recent research shows that semaglutides change the level of activity in reward-related areas of the brain in response to alcohol cues.
And so even though we might not be able to really definitively point to and say, okay, like it's the action of, the drug is definitely getting to this part of the brain and it's acting on this receptor, what's happening, the downstream effects, whether those are coming from the periphery or from the brain, are impacting the reward system.
Meaning that it's changing how alcohol makes someone feel. DeFelice-Antonio recently published her own study in Scientific Reports on the effects GLP-1 medications have during alcohol consumption. Her team specifically studied the pharmacokinetics, which refers to 4 core processes: absorption, distribution, metabolism, and excretion of substances.
So the reason we're talking about pharmacokinetics there is that for potentially addictive drugs, every potentially addictive substance, part of its abuse liability is how fast it gets to the brain. And so a really good illustration of this is nicotine, because nicotine in a cigarette we know is an addictive substance. That same amount of nicotine in a transdermal patch is a smoking cessation aid, right? And so the drug is the same, but the route of administration is changing how fast it gets into your body and therefore how fast it gets into your brain. And so when we're thinking about a drug's abuse liability, we do have to think about route of administration. And then if we're thinking about things that can alter, even if we're in the same route of administration, thinking about things that can alter the rewarding effects of a drug, slowing down how fast it gets to the brain is a way that should be able to do that.
20% of the alcohol you drink is absorbed into the bloodstream through the stomach lining. Then the rest is absorbed after it leaves the stomach and moves into the small intestine. Once in the bloodstream, it gets to the brain within minutes.
But we can slow down how fast alcohol gets to the blood by it spending more time in the stomach, right? Because in the stomach, it's not going to be absorbed as well. You need to empty from the stomach to the upper intestine to really get that excellent absorption into the blood. And so if we change that, we can change potentially the rewarding effects of the drug based on this idea of the faster it getting to the brain, the kind of more rewarding it is and the higher the abuse liability.
Which is where GLP-1s are coming into play. The hormone regulates blood sugar levels and appetite partially by slowing down gastric emptying, which is the process that transfers food in the stomach into the small intestine. For DeFelice Antonio's study, participants were split in two groups. One where everyone was on a maintenance dose of a GLP-1 and the other group served as a control. Both were given a standard serving of alcohol to see how fast their breath alcohol concentration would get to 0.08%.
We saw a slower rise in the breath alcohol in people taking GLP-1 medications compared to weight-matched controls for not taking those medications. The big difference is in that first 20 to 30 minutes, and that's that first 20 to 30 minutes, both in our measurements of blood alcohol and in our subjective effects. And so it's not that, people are getting less alcohol in their blood and they're saying, I feel just as intoxicated. They also feel less intoxicated. So that kind of is lining up nicely as far as their subjective effects, how they are experiencing the drug matches up with their blood alcohol, but it's delayed. And it's that really first 20 to 30 minutes that's really different. And then the lines start to come together.
The team believes this gap is due to the alcohol spending more time in the stomach and not being able to be absorbed into the bloodstream as fast as usual. But there's also an idea that increased nausea could play a part, since that's a main side effect of many of these GLP-1s. However, DeFelice Antonio says they didn't find any differences in nausea between the two groups. Still, she says it could just be the nature of who was participating.
We were recruiting people who had been on GLP-1 medications and had been on their maintenance dose, right? And people who feel a lot of nausea from the GLP-1 medications, they don't make it to the maintenance dose, right? They often stop taking the drug. And so it could be really different, right? If we, captured some of those people who are maybe kind of stepping up to their maintenance dose. The effects that we saw in this study in person, we also had people rate the kind of aversive effects of alcohol, like, are you feeling bad from the alcohol? And we didn't see any differences. We mainly saw differences in the subjective experience of being drunk.
Though this research is still in the early stages, it's an exciting avenue for addiction medicine. You can find more information about Alex DeFelice Antonio and all of our guests on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.